Okay, perfect. All right. Well, let's go ahead and get started. Good afternoon and welcome to today's Ask the Expert series brought to you by the Illinois Prescription Monitoring Program and SIUE School of Pharmacy. A couple real quick friendly reminders. Number one, this is an informal session and is not approved for continuing education. If you are looking for some high quality free CE on safe opioid prescribing and opioid use disorder, I would strongly encourage you to visit either the SIU School of Medicine CE portal or the Illinois Pharmacist Association CE portal, where you can find numerous modules that were supported by the prescription monitoring program. This session will be recorded and available for review along with past Ask the Expert series or sessions, and that is available on the Illinois PMP YouTube channel. And now I'd like to welcome our guest expert, Dr. Sarah Toppins. Dr. Toppins is a clinical pharmacy specialist at the HSHS St. Elizabeth's Hospital in O'Fallon, Illinois. Dr. Toppins received her PharmD from the University of Health Sciences in Pharmacy, and then went on to complete a PGY1 residency at St. Elizabeth's and a PGY2 in pain and palliative care at the St. Louis VA. And Sarah, I have to say, I'm really grateful for you agreeing to join us today and share your expertise.
Happy to do so.
So it looks like my camera shut off.
Yep.
But you can hear me. All right, I'll work on that. But so the first question that I wanted to ask you is, what are the limitations to traditional induction strategies when we're using buprenorphine and naloxone when treating opioid use disorder?
So I think the first and the biggest limitation to using the traditional induction strategy for buprenorphine, which is also the strategy that's cited by the FDA label and several practice guidelines, is that the patient must be in moderate opioid withdrawal, which is defined as having a COWS score of 13 or higher. However, the 2020 American Society of Addiction Medicine guidelines do state that a COWS of 11 or higher is indicative of sufficient withdrawal. I think regardless, though, any withdrawal is uncomfortable and can be a barrier to treatment initiation, and is also a common reason why patients leave care against medical advice or return to use in the community setting. The traditional induction strategy also has the potential to potentiate withdrawal or worsen current withdrawal. And this is due to buprenorphine's high binding affinity at the mu-opioid receptor, and it displaces the full mu-opioid agonists, like your traditional opioids that you think of, oxycodone, fentanyl, morphine, from the receptor. And actually, this risk is higher. This risk of precipitated withdrawal is higher in those patients who are using fentanyl or other high potency synthetic opioids that are like fentanyl derivatives, because of those high potency synthetic opioids' unique pharmacology and their ability to linger in the tissues longer than other opioids such as morphine or hydrocodone. Traditional buprenorphine induction strategy within 24 to 48 hours after the last fentanyl use has still been associated with a significantly greater risk of buprenorphine precipitated withdrawal than when you give it 48 hours or more after last use. So this can be, a very uncomfortable time for patients waiting till, 24, 48 hours or longer before they can start treatment. Another problem with it is that patients with co-occurring chronic pain, this transition not only can increase risk of precipitated withdrawal with this induction strategy, but can also increase the risk of like an acute pain exacerbation. Patients have to wait at least 12 hours to start buprenorphine when they stop their short-acting opioid like oxycodone, hydrocodone, and they have to wait at least 24 hours after stopping a long-acting opioid like an extended release product, OxyContin or morphine. And then it gets a little more hairy whenever we're talking about methadone and when we can start it.
Okay. Well, thank you. We also treat opioid use disorder in our family medicine clinic and have noted that with the traditional induction method, unfortunately, we have had a few patients return to use pretty quickly after being exposed.
Yeah.
So the kind of the new hot topic out, it seems like, is this microdosing induction strategy. And I was curious what your thoughts were. Are there pros? Are there cons to doing it that way?
Absolutely. So I'll start with the pros. So another term for this micro dosing induction strategy is low dose overlap initiation. So the idea is that while the full mu agonist is being tapered or, slowly getting removed from the body, you are titrating up buprenorphine from really small doses to a more stable maintenance dose, so to speak. Its biggest benefit is that sets it apart from the traditional induction method and the macro dose induction strategy, which we'll I'm sure talk about, is that the patient does not have to be in withdrawal. In fact, they shouldn't be in withdrawal whenever we start this. So that is a huge pro. Um, in those patients, though, and also in those patients using fentanyl, this strategy we typically start before the 24-hour mark, right? Because we would expect withdrawal to occur by like hour 24 or more. Um, because of this, it has a lower incident of precipitated withdrawal than the traditional induction method. And there are several studies that are published with various different types of low dose overlap methods. They all seem to show that the incidence of precipitated withdrawal is pretty low. And in my experience using it, it's never happened, which is good. Now, if it does happen, usually the way we would treat that is switch over to more of a traditional method, or if the withdrawal is so severe, starting with those higher doses, getting you right up to that maintenance dose really quickly. But overall, it seems to be pretty low. It's also a good method for patients with opioid use disorder who abuse or misuse prescription opioids, since the full mu agonist can be simultaneously tapered while the buprenorphine is being titrated up. Because of this, the speed of the microdose induction can be customized based on patient and provider preference. So when I have patients out in my like pain clinic who are used or prescribed opioids for their pain, but also have signs and symptoms of opioid use disorder, and we decide we're gonna, switch you over to buprenorphine, we mutually agree on that decision. I mean, I've gone as quick as a week, titrating them onto buprenorphine and tapering them off of their full mu agonist. And we've gone as slow as, 3, 4, 5 months, right? So it really, it's nice because it can be customized, and you can use it in patients, misusing or abusing the prescribed opioids or really the street opioids too, right? Now, the biggest limitation, though, with that being said, is it does take several days. So, especially in those patients who are seeking detox from fentanyl, and they're admitted into the hospital or into an inpatient like psych rehabilitation site, for instance, patients can sometimes become really impatient or anxious that the withdrawal symptoms are going to occur at some point. In these 5 to 6 days where we're transitioning them onto their maintenance dose of buprenorphine. And they sometimes leave against medical advice, or if it's happening in the community, they'll return to use before we get them to that maintenance dose. So, kind of like what you said about the traditional induction method, the same thing happens with the microdose, which is, a downside to starting treatment before the withdrawal happens in those patients that are using fentanyl. Another huge limitation related to this is if you're doing this in the inpatient setting, you really have to be mindful. Federal law still restricts medications for opioid use disorder administration to 3 days if the reason for inpatient admission is opioid use disorder. There's some ways around this. If the patient is also admitted to the hospital for another diagnosis, and that could be the primary diagnosis, then you are able to extend treatment beyond 3 days for the purpose of detoxing or maintaining for opioid use disorder, but the law does get very tricky. So
Yeah.
because it takes several days, though, even if you can figure all of that out, keeping someone in the hospital for 5 days for this isn't really ideal and increases costs, of course. So with that being said, another limitation is formulary insurance and state laws. So to start with formulary, in the inpatient setting, at least at my hospital, we only carry the sublingual formulations, which are approved for opioid use disorder. However, most of the published dosing strategies incorporate those lower dose products that are indicated for pain, which is the buccal films and the transdermal patch. And in my experience at the VA, I often would start this method with the transdermal patch and, titrate up to the sublingual doses.
Mhm.
So where I'm at right now, I can't use the transdermal patch. Another thing that could limit this in the outpatient setting is insurance. Insurance may not cover these buprenorphine products that are indicated for pain for OUD purposes, right?
Mhm.
I believe there are some states, not Illinois, but I do believe there are some states in this country that limit the use of the different buprenorphine products depending on the indication. So that's enough, could be potentially another limitation. So there are ways around this. If I were to do this in my hospital right now, a microdose induction strategy, I would simply start with like cutting the films or the tablets, whatever product we used, into quarters. It's not ideal, but those low doses should be somewhat equivalent to the doses provided by the patch or the buccal film, and kind of going up from there. I have several dosing strategies. If you're interested in learning more about the different microdose and induction strategies, I'd be happy to share those references with you all. But it does get a little more tricky when we're talking about dosing, when we don't have all the products available to us.
If you would send me those references, I'll put them in the comments under the YouTube posting once we
Sure,
post this. Well,
sure.
thank you for that. Now, before we move on to macro dosing, since we're still talking about microdosing, I
Mhm.
wanted to get your opinion on a patient that we're working with right now that was a 6 to 7 time a day use pattern of fentanyl. We started the Bernice method of microdosing where, we step up over basically 7 or 8 days. The patient was able to cut their fentanyl dose, on day 8 when we got to the full buprenorphine target dose, was able to cut their fentanyl use by 2/3, but is not able to put down that final third of the dose. And I'm wondering if you have had this experience or if you have any tips for me.
So in my experience, I've never, unfortunately, I didn't get to work in our low barrier clinic at the VA. Our low barrier clinic, sort of accepts the fact that, we're gonna treat patients regardless of their return to use, right? Obviously, the goal is that they don't continue to use fentanyl. But I was unfortunately not in that setting. My experience is strictly in the outpatient pain clinic setting where I'm treating patients with prescribed opioids, right? And didn't if they were to misuse street opioids, then they would be treated by like our either our methadone clinic or our psych providers. And then my other experience is in inpatient unit. In the psych unit at Jefferson Barracks. And so they weren't continuing to use fentanyl there either. So I actually don't have experience with the low dose overlap while a patient is continuing their street opioid use. But I would say, and this kind of goes into what we'll talk about with macro dosing, I would probably say just starting them on that maintenance dose. I don't know what dose you're at right now, but a 16 milligram at least. Because the higher we get up on the buprenorphine dose, the more receptors the buprenorphine occupies, right? And is able to block the fentanyl from binding. I don't feel like it's going to increase their risk of respiratory depression. If anything, I feel like it would reduce their risk because then the fentanyl wouldn't be binding as much as if you were using lower doses. But I would just have to say, like, either go big or go home, because if you don't go big, then you risk precipitating withdrawal, right? And that's kind of what I'll talk more about with the macro dosing. So Chris, what dose do you have them on right now?
I have them on 12 milligram Q12.
Okay, Q12, great. Yeah, and that's interesting. There are some studies to suggest that even 32 milligrams maintenance dose might not be enough for some of these patients using fentanyl and their derivatives. So it's not as surprising to me that a 24 milligram dose is not cutting it for them. Have you tried, I guess, putting an 8 milligram dose in place of that third dose for that they're still using of their fentanyl?
Not yet, but that's a great suggestion. I will try it.
Okay. Because I do feel like I said, if you increase the buprenorphine dose, I think there's pause, because with any drug you think about increasing doses increases risk for side effects, right? The way I think about buprenorphine, and this kind of gets into some more about what I would talk about under the macro dose. But when you think about buprenorphine, it's better to, I guess, displace these higher risk opioids like fentanyl that we know increase risk for respiratory depression and death at higher doses from the receptor faster with buprenorphine, which has a ceiling effect on respiratory depression. It would be better to displace them as quickly as possible, right? Knowing maybe that the patient is continuing to use fentanyl, but at least I know that the buprenorphine is binding more to those receptors than fentanyl. Therefore, it's safer. Does that make sense?
Yeah.
And I think there's pause to do that because you think, oh, we're going to add respiratory depressive effects, right? We're going to increase the risk if we go up on the dose while also continuing fentanyl. But there's several studies out there actually that have been published in the low barrier clinic setting where we assume patients are continuing to use fentanyl. In fact, they'll report continued fentanyl use. And even the 32 milligram dose is not completely reducing their cravings or return to use. So what that says to me is that even the 32 milligrams, they're taking it because it's showing up in their urine drug screen. We know they're taking it, but they're still returning to use to that fentanyl. Even the 32 milligrams is not effective enough, but we know it's safe enough because, nothing's happening side effect wise in these studies.
Okay.
So it's very interesting to think about, and it kind of goes against what we learned as pharmacists, which is to, reduce doses, reduce additive effects. But if anything, it's a safer alternative than them using fentanyl, right?
Sure. Well, and that's probably a great segue to the next question. So we talked about standard, we talked about micro. Now,
Yeah.
obviously, we got to talk about macro, and that's probably the newest discussion of induction strategy. And I was curious what you might be able to share with the attendees regarding macro dosing. I know you've helped me do it on one occasion, and we had a good outcome. But
Yeah.
please, what is macro dosing and why and where?
So I'll first start by saying, so specifically when we're talking about those patients who are using high potency synthetic opioids like fentanyl, like I kind of mentioned, giving a high dose of buprenorphine is a much faster way to start medications for opioid use disorder in these patients compared to the two other methods we already talked about. Because we have data to support that when we start treatment, we can also stabilize them on the same day, oftentimes within 3 hours on average, which is really nice to do in like the ED setting, for instance. So when buprenorphine is given at doses of 16 milligrams or higher, there is enough buprenorphine to provide relief of withdrawal symptoms after that full agonist opioid are displaced from the mu-opioid receptor. So when you give those lower doses, though, the 2 to 8 milligrams, only some of that full agonist is displaced. and then we don't get full relief of withdrawal symptoms. So that's whenever we see the most precipitated withdrawal, is when we're talking about those traditional induction doses, because only, like I said earlier, you either go big or you go home, because only a little bit is getting pulled off of the receptors. And what's happening is then only a little bit of the buprenorphine is binding, and then there's still drug present, like fentanyl lingers for quite some time, right? So it's trying to bind back, and you've just got this kind of in between phase where you're going back and forth with it binding and getting displaced. And that's whenever we have precipitated withdrawal. So what really is ideal is to pop the full mu agonist off all the receptors with a big dose. And then buprenorphine is going to bind tighter than fentanyl and other opioids, and it's going to bind longer than fentanyl and other opioids. So it's key to get that big dose in there. Now, I'll preface that with saying, I'll kind of talk a little bit more about this in the limitations, but this is not the dosing strategy I use for your grandma who's got undertreated pain and is using more of her hydrocodone than she's prescribed, right? This is not what I'm saying. I'm talking about those patients who are intentionally or unintentionally consuming fentanyl and its derivatives, right? So not only do we have faster relief of withdrawal symptoms, but we also know that this can be used to speed up the transition to not only a maintenance dose, but if your maintenance product of choice, for instance, is a long-acting injectable, this can speed up the transition to that. The Sublocade injection is a monthly injection, and per the FDA package insert, you have to be started on a sublingual Suboxone prior to using the injectable product. Now, there are some studies coming out to support a micro-induction strategy with the long-acting injectables. The way it works is it starts to get to steady state over about 24 hours. So stay tuned for stuff regarding that in the future. But for now, it's recommended by the labels for both Brixadi monthly injection and Sublocade that you have to start with the sublingual Suboxone. So this strategy can kind of speed up that transition, providing the patient with, month-long protection. Another thing is faster relief of withdrawal symptom is so important for patient buy-in. Like we kind of talked about, patients get impatient. Their experience in the past has been poor, where they've had precipitated withdrawal, or just simply the anxiety of waiting for withdrawal symptoms to happen can make patients not even want to try to detox to begin with, right? So this can be really good for patient buy-in. The way I kind of sell it to patients is, whenever you start having a little bit of withdrawal, and these patients know what their withdrawal symptoms are, right? They know, oh, I know because I start to feel a little nauseous, or I start to get kind of sweaty, right? The second that happens in practice, that's whenever we've started the dose. Usually that's about 24 hours, a little more, in our patients using fentanyl. However, I do want to preface by saying the studies that are published out there did not start macro dosing until cows score greater than 8. But like I said, in my experience, it's usually just whenever the patient's starting to have even mild withdrawal symptoms, that's whenever we've started it and had good luck. But regardless, I think even if you waited till a cow's of 8, right, it's still not as bad as waiting till a cow's of 13, like you would have to with the traditional induction method. And the idea is that those withdrawal symptoms will subside once that drug kicks in, right? So they're not sitting in withdrawal very long while they're getting to the maintenance dose, because you get to the maintenance dose really fast, unlike the traditional method or the microinduction. I like this method too for patients using street opioids, because kind of like what I said before, it's better to displace these highly potent synthetic opioids from the receptor as soon as possible, rather than those slower initiation strategies, since fentanyl has such a long duration of action with continued use and has significantly higher risk for depression and death. And I feel like it's just a no-brainer why we should be, giving people buprenorphine rather than fentanyl, right? Another thing to consider, and I think this is really important, is that from my experience so far and my mentors and preceptors' experience at the VA, is most patients reporting illicit drug use, pretty much everybody reporting illicit drug use, whether it's cocaine, methamphetamine. When we do those urine drug screens, fentanyl is always on that urine drug screen. Patients are unintentionally consuming fentanyl when they're using their drug of choice from the streets. So they may not even know that they're dependent on fentanyl, right? They may not even know that they're gonna go into withdrawal from fentanyl. I think it's really, really important that our urine drug screens still screen for fentanyl. And unfortunately, at my current institution, we do not. So it's particularly challenging for someone like me to try to convince the physicians that this is a very real possibility that we might expect some withdrawal from fentanyl in our patients who are withdrawing from methamphetamine or cocaine. So it's really important that we advocate to get the urine drug screening methadone panels or urine drug screen panels with fentanyl on it. Oftentimes, so this is a send out lab and can complicate things. Nonetheless, for the most part, everybody in this area, I'm in St. Louis at least, so everybody in the St. Louis area that I've seen urine drug screens come back positive for methamphetamine or cocaine have also had fentanyl on it. So because of this, these patients are tolerant to high doses of opioids, right? And I think a big thing to consider is because they're tolerant to high doses of opioids and fentanyl, right? They should tolerate large doses of buprenorphine without sedation or other adverse events. But keeping in mind too, with increasing doses of buprenorphine, you have a ceiling effect on respiratory depression, unlike other opioids. So in conclusion, the more buprenorphine given in a shorter period of time, the more there is available to tightly bind to those receptors and can therefore prevent or provide relief of withdrawal symptoms, but also reduce the risk of fatal respiratory depression from fentanyl. Limitations though, so I kind of talked about, I will not use this in patients who are not using highly potent synthetic opioids. So again, not a good idea to use a 24 milligram macro dose in a patient who's just misusing their prescribed opioids, right? I would use more of a micro dose induction in those patients. There is also a lack of evidence to support the use of macrodose buprenorphine in absence of any signs or symptoms of opioid withdrawal. Like I said, and in my experience, I haven't had to get them to a cows of 8. They've just had to report some type of withdrawal starting to come on, because the idea is I want to make them as comfortable as possible, as quickly as possible. But if you're playing it by the books, the only published data we have out there is a cows of 8 or more. So keeping that in mind, that would be what I recommend for now, until we get more published data to support the use of macro dosing and more mild or no withdrawal.
Now, macrodosing, it's traditionally utilized, or at least was first described in the ER setting or the ED setting. Is that,
Yep.
Is there published information on this being safely done outpatient as well, or not?
Nope.
Not yet?
Not yet. No.
Okay.
So, and that's the thing, is the study I am citing so much is that 2021 study that was published or took place in the ER. For those not familiar, there's actually a website, it's called California Bridge. It's a really great resource for all things substance use disorder for patients, for really, it's like they have a bunch of hospitals and then some low barrier clinics. So a lot of their resources are guides on how to start treatment in the hospital, which I really like to use since that's my practice setting. But they also have some low barrier clinics, I believe, as well. But it's a big campaign that's been going on for years. And one of the products of that was a 2021 study where they used the algorithm that you can find on the California Bridge website. They used that in their hospital, and they did a retrospective case series performed in ER patients. And what was nice was it kind of broke down those patients that the providers decided to use more of a traditional induction method and those patients that they decided to use a macrodose induction method, and they compare both of those, which I really like. It shows even more the benefit of a macrodose induction strategy. So I encourage you to read that study, but that is right now the only good quality evidence for macrodosing. And I think, Chris, you were probably going to, you mentioned to me, or you mentioned that me and you did treat someone in the outpatient setting. I just want to be clear that there is no data, but that doesn't mean it's not being done by people. Hopefully we get some publications so out of what people are doing.
Yes, I do hope that.
Yeah.
Okay, last question, and then we'll see if anybody else has questions or things to share from the audience. But plain buprenorphine versus buprenorphine with naloxone.
Yeah. So my preference is, again, because I work inpatient, my preference is buprenorphine monotherapy. Okay. So when we think about buprenorphine naloxone, why do we have naloxone in the buprenorphine product? It's an abuse deterrent, right? The idea was and is that, a patient can't melt down the film and inject it and get, high off of it, because what will happen is when they inject the naloxone, it'll cause systemic opioid antagonistic effects, right? Causing the patient to go into withdrawal. However, we do know, based on really what the FDA label or the manufacturer has said, that some naloxone absorbs. We also know that based on urine drug screening results, that naloxone in this buprenorphine naloxone combination product is getting systemically absorbed because we're finding it in our urine drug screens. So it begs the question, does this make a difference in your efficacy of the medication? Does it cause withdrawal? Can it worsen pain? Anecdotally, my experience has been in clinic that patients who have switched from the combination product to the monotherapy product, some patients have reported better pain relief on the monotherapy product. And some patients have also reported on the combination product some breakthrough withdrawal or cravings. Really, cravings is the big one at the end of the dosing interval, which seems to be relieved when they take the monotherapy product. So there is something going on here. However, I will say when it comes to what's published out there, there is no difference in clinical outcome data, whether it's cravings, withdrawals, analgesic effects. Nothing's published that says, the monotherapy product is better than the combination product. So from my perspective, inpatient, I see no use for the combination product. In fact, one thing I'm going to try to do is get that removed from our formulary, because we're administering it, right? Our nursing staff is administering the drug. There's no risk for abuse on the patient end of things in the hospital setting. And there is theoretically or potentially a risk for, reduced analgesic effects, potentially precipitated withdrawal symptoms, maybe, or just overall reduced effects of cravings or getting them to a more stable state. So I don't see a purpose of using in the inpatient setting. In the outpatient setting, I think it should be a risk versus benefit kind of individualized decision with the patient. Like I said, if you have a patient who you're not worried is going to inject it, they don't even have a history of injecting opioids. Maybe their opioid misuse is just prescription opioids in the past or what have you, but they're reporting some breakthrough cravings or withdrawal symptoms at the end of their dosing interval, or their pain's not well controlled at the end of the dosing interval. I think it's super reasonable to switch them to the monotherapy product and see if it works better, right? But overall, that's my preference personally. But unfortunate. Oh, and another thing to add too is all the studies too, like the 2021 ED study I'm referring to, they used the monotherapy product. Even the FDA labels, when you're talking about traditional induction, does say to start with the monotherapy product on day one. And whenever you get to the maintenance doses, that's when you switch over to the Suboxone product. So it is kind of subtle that monotherapy is more preferred when we're starting treatment. But there's no clear evidence to support that one is better than the other, if that makes sense. So that's
Okay.
just my preference, at least.
Hey, that's why we have you here is to find out what you're doing and why. So thank you very much for taking some of those questions. I would like to open it up to the audience. Um, I think that there is one question. It says, my question is for those patients who are using fentanyl and have come through the ED, how soon do you recommend repeating the macro dose after the first dose? Is it
So
based on a certain cow's, or do you
yeah.
have another threshold?
So if I'm gonna cite the one study that's published and that dosing guidance that's published on the CA Bridge website, what they did in their methods was they started people out on an 8 milligram dose. Okay, 30 to 16 minutes later, they performed the cows assessment again, and if the cows was still greater than 8, then they gave them anywhere between another 8 milligrams up to, I believe, additional 24 milligrams. So for up to 32 milligram total dose. Okay, so they
Mhm.
didn't really macro dose them until that second dose, which I find interesting because personally, and in my experience, I at least start with a 16 milligram, and I've started people with a 24 too, right off the bat. So I think if you're going to go off of what's published out there, which if you're creating a protocol for your hospital, or you're we're recommending to providers on what to do, we should be using evidence-based medicine, right? That's what's published out there. But I will tell you, people are starting with the macrodose right up front. And then in my experience, what I've done in those few patients that still had breakthrough withdrawal symptoms hours later, and I'm not talking precipitate withdrawal, I'm saying breakthrough withdrawal symptoms. So 8 hours later, I've just given them another 8 milligram dose. So I hit them with a 24 in the morning. And then at bedtime, they're like, I feel like I'm sweating again, or, having cravings or whatever. We gave them another 8 milligrams, and that seemed to do the trick. So I think it's patient specific. My recommendation personally, I would prefer to hit them with the bigger dose first and then a smaller dose later on, because when you do the 8 milligram dose, you do risk potentially precipitated withdrawal with that first dose, right? But the study itself says a cows of 8. That's kind of
Okay.
their cut point.
Okay. Thank you. Um, Now, if you don't want to pose a question via the chat or the Q&A, please feel free to unmute and ask a question that way, or put your video on or raise your hand. This is laid back and informal, so
Hi, my name is Kelsey. I'm a PGY2 in emergency medicine in Rockford, Illinois, and I was wondering if you had any advice as far as kind of jump starting buprenorphine utilization from the emergency department.
Yeah, I'm actually currently working on this right now at my institution. Well, I've started on a protocol with a champion physician at one of our Wisconsin hospitals, and we're mimicking that 2021 ER study. If you're not familiar with it, I'd start there. That is a great study, and using that CA Bridge website, they've got different algorithms, especially when it comes to treatment of the withdrawal symptoms. It's very helpful to use that. But I'm kind of in the same boat as you right now. I'm trying to get it jump started. I think my biggest barrier at my hospital will be identifying those patients, because currently our urine drug screen there does not test for fentanyl at all. So unless a patient tells me or our providers that they are just use fentanyl, I have no way of saying for sure that it's present in them, even whenever they pop positive for methamphetamine, for instance. Um, but I think starting there would be best. If your institution already has fentanyl testing, just making sure that anybody that's getting urine drug screen, you add that on would be my first step. And I think you've got to find your champion physicians too. I know a lot of the providers I work with in the ER are excited about this. They want, to try these things, and they have tried them. From what I've been told at least. They've tried the 16, 20 milligram doses, and the patients have done just fine. But so far since I've been back, I've not gotten to do it at my hospital. So
Thank you. Yeah, we've tried to implement the California Bridge program, like those studies, and replicate that. We do have a clinical pathway in place that's similar, but of course varies enough where they're not the same. But we do have an issue with warm handoff and kind of establishing those relationships with maybe clinics in town, especially since there are some clinic representatives here. Do you have any advice as far as establishing those relationships to facilitate the warm handoff?
that is my exact problem. So I'm even having issues with the transition into if they're getting admitted and passing off to the hospitalist team. A lot of those hospitals at my institution are reluctant to continue high doses. That's been so far my experience. And then a big barrier I know at my institution is that transition. So part of what I am hoping to establish eventually, I'm new in my role, but part of what I've been hoping to establish eventually is more of I would like to do like a telehealth transitions of care model for those patients in those first few days while we're trying to get them established with care in the community. I'm hoping I can be the one that can check in on them, see how they're doing, because those first few days are really critical to maintain people on treatment, make sure that they don't return to use, treat their breakthrough symptoms. That's another big thing that I don't think is being done. And so my hope is that I've collected a lot of literature, and I'd be actually happy to have a conversation with you going forward. I can share some of this literature to support the use of a pharmacist role in this transitions of care, but I just have yet to implement it myself. But that is my goal, and there is literature out there to support the use of us helping with that transition. So it's really exciting, but I'd be happy to share more with you.
Yeah, I would love to connect. That sounds great.
Yeah.
Kelsey, I will send Dr. Toppin's email address to you. I'll have your contact info from your registration. Any other questions or comments? This has been great.
Hey, I have a question for you. My name's Will. I'm the opioid stewardship pharmacist at the Franciscan Physician Network. It sounds like you have at least one patient experience of doing this outpatient. I'm a little bit curious to hear how you guys decided to utilize the macro dosing for that patient.
Yeah. So I'll start with this. There's no direct evidence, like I said. There's a really good study that was published last year in 2024, and let me get you the exact title of that. And this is a very roundabout thing, so bear with me on this. Essentially, so this study was done in a low barrier clinic model. Okay. It's called dose specific clinical outcomes in patients with opioid use disorder treated with 24 to 32 milligrams per day of buprenorphine. So my thought process was with this study, the patients were allowed to continue their 24 to 32 milligram dose of buprenorphine, right? Regardless of reports of return to use with fentanyl, regardless of adherence to the regimen, as evident by the urine drug screens performed. And honestly, the way this study shaped out was it looked like patients were still using fentanyl. They were reporting it. It was showing up in their urine drug screen. Sometimes they were still using buprenorphine. Sometimes they weren't, as evident by the reports in their urine drug screen. And to me, that speaks patients in real life, right? They're not adherent to their medications in general. We know this. And they're going to have slip-ups. They're going to return to use. What's interesting, though, is the study went on for months and months and months and months and months, and patients retained in clinic for a very long time. So they were continuing to show up, and they'd go back and forth with taking their medication, right? So I kind of thought, all right, that means that patients are saying one day I'm going to take the medicine, the next day I'm going to go use fentanyl, because that's essentially what some of these results showed. It made me more comfortable to start, Chris and I had a patient who admitted to us, she was using like 4 caps of fentanyl. She hadn't been taking her buprenorphine. And without sending her to the ER to get, restart on treatment, we kind of pulled the results of this study, some of my experience with the macrodose on the inpatient side of things, and told her, wait 24 hours since last use, because she remembered when she last used it. So I said, wait at least 24 hours. I encouraged her to wait until she started to have a couple signs and symptoms of withdrawal. Like I said, patients, they know when their first few signs, right, of what their withdrawal looks like. Said, wait till that happens and take the 16 milligrams. In my experience, I've usually done the 24 milligrams inpatient, but Chris and I were just a little hesitant to do that on the outpatient side of things because we don't have monitoring or anything like that. In fact, this is going to happen after hours too, because I think her last use was in the evening the day before. So we were a little nervous to do any more than 16, but what I told her was, if you start to have more withdrawal symptoms within an hour or so,
Okay.
take another 8 milligram dose. And what happened was she didn't need that extra 8 milligram. In fact, it sounded like she tolerated the 16 just fine without any return of withdrawal symptoms. Am I correct in that, Chris?
Yeah, she did great. So thank you for that help.
Yeah. But I really encourage you all, if you're doing this in your practice, and Chris and I really need to publish that as a case study. We need to start publishing this because people are doing it, so no one's publishing it. And that's what's making some of us more hesitant to try these new things. But I think the big takeaway should be, this is still safer than fentanyl. So whatever I can do to get someone on to safety faster, I'm gonna try. But of course, because we don't have those studies to say this is safe to do outpatient, that's what makes me a little nervous, right? And I'd prefer them come to the ED if possible for now. But I think the big takeaway is this is always safer than fentanyl, right?
Okay, thank you. Anybody else or any other comments?
Hi, this is Courtney Potempa. I'm a physician assistant in Illinois. I work both inpatient and outpatient. I'm the lead medical provider for Footprints to Recovery in Elgin. So I just kind of want to offer myself up both as like the warm handoff from a hospital. We would love if you have patients that are needing, the inpatient level of care, the residential level of care, and we cover all full continuum. And then I also have a private practice outpatient where I see most of the substance use in our group because buprenorphine is my favorite drug. So I wasn't able to add my information in the chat, but I'd be happy to hand off my information if any of the attendees are finding it difficult to find providers to take over care.
That would be fantastic. And I think that's probably everybody's biggest barrier. I was fortunate enough last year to be training somewhere where we had all of the resources that we could give to our veterans in our local area. It's just not the case in the community, and that's going to be my biggest barrier going forward. And then also reducing the stigma within our institution itself. But that's my perceived biggest barrier right now is once I stabilize these patients, what do we do with them? And I'm still trying to figure that out myself. So please share your information. That would be so helpful. I appreciate it.
Sure. Chris, are you able to pull my information from the registration?
I am, yes, ma'am.
Awesome, thanks.
And I'll send that on. Could you tell us one more time where your practice is located?
Yeah, sure. So Footprints to Recovery is the inpatient all the way through outpatient level of care. It's in Elgin, Illinois. Okay. So close to Rockford, close enough to Rockford. And then my other practice, my private practice, which is all outpatient general psychiatry, is Hope Mark. And we have locations kind of all over. We've got, we have a downtown office, Orland Park, Oak Brook, Naperville, Hoffman Estates. I feel like we might be missing another one. But so we do cover a good span to cover a lot of patients.
Okay. Well, thank you for signing on today and sharing your information. I think we're about at time to wrap up. Again, please join me in thanking Dr. Toppins for sharing her day off, as it were, with us today to share her practices and insights. And please stay tuned for future Ask the Expert sessions where we will do another informal kind of sharing of ideas and best practices. So with that, thank you, and I hope everybody has a wonderful day.
Thank you, guys.